Hello, my name is Patrick. Welcome to my channel. In this video, I am going to discuss neurology. We have read about someone or heard about someone who ended up with stroke, and we wonder, how does that even happen? Well, in this video, I'm going to do my best to delineate those things, and I'm going to walk you through some of the signs and symptoms that you need to watch out for if you suspect that someone is having a stroke. So let's get started. Number one, what are 3 symptoms that you have to keep your eyes on if you suspect Parkinson's disease? Let's find out. So number 1 is resting tremor. This is more like their hands moving even when they are at rest. It's like rolling up a pill. Then another thing to watch out for is shuffling gait. You might also see maxed faces. All right, so again, 3 symptoms to watch out for when it comes to Parkinson's: resting tremor, shuffling gait, and maxed faces. Next, what is the first line treatment of Parkinson's disease? All right, so you know someone has Parkinson's. What is the first line treatment? How are you going to treat it? The answer is levodopa, carbidopa. Okay? Levodopa, carbidopa. Next, name 3 drugs that can be used to treat cluster headache. All right? I think I made a video where I explained the 3 primary types of headaches. So if you haven't already watched that video, I encourage you to do so. But this question is asking what 3 drugs can be used to treat cluster headache. The answer is 100% oxygen, and then you can do sumatriptan, and you can use verapamil as a prophylaxis. All right, so first you want to give oxygen, 100%, and then you can give sumatriptan, and in terms of future prevention, you can do verapamil. All right. Next, what is the triad of normal pressure hydrocephalus? Okay. What 3 things are you likely to see if you suspect normal pressure hydrocephalus? The answer is 1, dementia or dysfunction when it comes to cognitive ability. Number 2 is disturbances in terms of gait. And then you can see things like urinary incontinence. All right. So this is high yield. Whenever you take exams, especially in neurology, you're likely going to get this question. I got this question in one of my exams. Next question, what will be the result? So if you analyze a cerebrospinal fluid, right, of someone who has bacterial meningitis, what result are you likely to see? This is another high yield because they want you to differentiate if the cause is bacteria or if it's viral. So when you analyze the CSF of someone who has bacterial meningitis, what's the result going to be? So everything, this is how I remember this. With bacterial meningitis, everything is going to be elevated except glucose. All right, so don't even think about it. Bacterial meningitis, everything will be increased except glucose. So glucose will be decreased. Next, what is the most common cause of encephalitis? What is the most common cause of encephalitis? The answer is herpes simplex virus 1. That's the number 1 cause. That's the most common cause. Next, how does multiple sclerosis present? So you suspect that someone might be having multiple sclerosis. What do you look out for? You're likely going to see sensory deficits such as pain, paresthesias. There could also be visual disturbances like diplopia or optic neuritis, and you might see decline in motor deficits, okay, in motor activities. So you can see motor deficits such as weakness and gait imbalances. And again, you can see sensory deficits, visual disturbances, and motor deficits. All right, those are the things you want to pay attention to, especially if you are thinking in the line of multiple sclerosis. Next, what is the most useful test that you can use to establish that someone has multiple sclerosis, and how do you treat it? So, in medicine, you suspect this is what someone has, but you got to prove it, right? You have to prove it. You can't just go by suspicion. So, in the previous question, we looked at the signs to look out for when it comes to multiple sclerosis. But now we have to prove it. So this question is asking, what is the most useful, right? So again, in medicine, there are so many things you can do. There are so many testing modalities you can use. There are so many options. But this question wants to know the most useful. And this is important when you're reading vignette or taking exams. You have to pay attention to specifically what it is that they are looking for. So the most useful test to establish that indeed someone has multiple sclerosis, that is MRI. Okay? That is MRI. And I got a question like this before, and the question wanted to know, do you order it with gadolinium or not? The answer is you have to order it with gadolinium. So the answer is MRI with gadolinium. And in terms of treatment, you want to give high dose IV, not oral. You want to give high dose IV corticosteroid for exacerbation. And then in terms of prevention and maintenance and making sure there's no relapse, no remission, you can do better interferon. But if they're having an exacerbation, you want to do high dose IV steroid. Once again, you suspect multiple sclerosis, the imaging of choice to establish without any doubt your diagnosis is MRI with gadolinium. So you confirm that, you establish it. The treatment is high dose IV steroid for acute exacerbation. But then, if you want to make sure that you prevent, and if you prevent relapse and remission, you can do better interferon. Next question, what differentiates Bell palsy from stroke? This is again another common question that you're likely going to come across, right? What is the difference between Bell palsy and stroke? Which cranial nerve is affected? How do you treat it? All right, it's not enough to know what it is, but you got to figure out how you're going to treat it, right? Let's find out. So the thing with Bell palsy is that it presents as a unilateral facial weakness or paralysis that involves the forehead. So patients are not able to wrinkle their forehead or the affected eyebrow. So this is where the distinction comes into play, right? In terms of stroke, and this is how I remember it, stroke spares the forehead. If you have stroke, you can be able to wrinkle your forehead. But if you have Bell palsy, you cannot be able to do that. That's a very key thing to keep in mind. Then another thing you can find in terms of how Bell palsy presents is that you're likely going to see drooping of the corner of your mouth, okay? So those are the things to look out for. But the key distinction is that stroke does not involve the forehead. So you're reading a medical case and it says the patient is able to wrinkle their forehead. That is not going to be Bell palsy. How do you treat Bell palsy? The treatment is mostly supportive. All right, you can do things like artificial tears. Make sense? Let's move on. In this question, you have decreased GABA, okay? And you also have decreased substance P. What are you likely thinking of? So decreased GABA and substance P should make you think of what diagnosis? At what age does this diagnosis begin to appear? What is the inheritance pattern? Okay, these are 3 questions we need to figure out. I'm going to give you a few seconds to see if you can figure it out. All right, so let's find out what this is. So this is Huntington's disease. All right, in Huntington's, there's a decrease in GABA and substance P, and it's more likely to present starting from the age of 30 to 50 years old. That's the time frame when you're likely to see Huntington's disease. All right. Again, this is a very important thing to remember. I've seen it in a question before. What is the inheritance in terms of the inheritance pattern? It is autosomal dominant neurodegenerative disorder. Okay, so it's autosomal dominant. Unfortunately, there's no cure. All right, that's the thing with Huntington's disease. Unfortunately, there is no cure. Next question. A patient has weakness that travels from the lower legs to the knees and hips. She's also displaying absent reflexes. What are you thinking? So this patient has weakness that is ascending. Okay, that's how it's going to likely present, ascending weakness. So it starts from the lower leg and it travels up to the knees as well as the hips. Okay, and there is absence of reflexes. What are you thinking? This is likely to be Guillain-Barré syndrome. Okay, I struggle to pronounce this. I'm still not perfect with it, but it's going to be Guillain-Barré syndrome. And how do you treat it? You can treat it with plasmapheresis or IVIG. That's IV immunoglobulin. Next, what is the most common cause of dementia? Okay, the most common cause of dementia is Alzheimer's disease. Okay, next, you do a histological studies and you see neurofibrillary tangles as well as amyloid beta protein. What are you thinking of? Again, Alzheimer's disease. All right. Next, patient has generalized body weakness. Okay, this patient is presenting with generalized body weakness as well as ocular weakness. So weakness of the eye, generalized body weakness. What are you thinking? How do you treat it? This is likely to be myasthenia gravis. Okay, so 2 things you have to remember when it comes to myasthenia gravis. Patient is going to come in, they're going to likely be complaining of generalized body weakness. Okay, and they're going to have eye weakness. They're going to have they're likely going to complain about diplopia, which is double vision, and you can see drooping of their eyes as well. So when you see those things, myasthenia gravis has to be high in your differential. In terms of treatment, you can utilize plasmapheresis or IVIG for crisis. Now, if you want to treat long term, you can use things like acetylcholinesterase inhibitor. Okay. Next, this patient has seizure. Okay, and the patient is also very young. Okay, and the patient is presenting with sudden impairment of consciousness, but their body tone is not lost. Okay, so they are staring straight up. They don't lose their body tone. And this is lasting between 5 to 10 seconds. What is it? This sounds like absent seizure. So let's go back to this. This is very important. So in absent seizure, it is most commonly seen in children. It presents as a sudden impairment of consciousness, but there's no loss of body tone. That's an important clue. And look at the time frame, between 5 and 10 seconds. Okay? So it is the most common type of seizure in children. Take that away. Talk it in. Next, so you examine an EEG, and it's asking, if you look at an EEG finding, what would you find in terms of absent seizure? So what EEG finding is associated with absent seizure? What is the first line medical management? So we've already established one thing, that absent seizures are most commonly seen in children. But then you have to do encephalogram, right? The EEG. And again, in science, in medicine, you suspect something, but you have to prove it to the patient that this is what they have. So you believe this is an absent seizure, you do an EEG, what are you likely going to find, and how do you treat it medically? So you're likely going to see bilateral symmetric 3 Hertz spike and wave activity. In terms of the first line medical management of absent seizure, it is ethosuximide. Okay? That's your first line medical management. Next, name 2 medications that you can use to treat peripheral neuropathy. Okay? Your patient comes in, they're displaying peripheral neuropathy. You're looking around, how can I treat this? What medications are available to me? Just give me 2. All right? The 2 that come to mind are amitriptyline, which is a tricyclic, as well as gabapentin. Okay? Those 2 are they're very good at treating neuropathy. All right? Next, what is the first line IV drug therapy for status epilepticus? Again, this is important. When you're reading a question, you need to know exactly what they're asking for, right? This question is not just asking for the drug therapy to manage status epilepticus. They are also asking, is it IV? Is it IM? Is it oral? Right? The first line IV drug therapy. But before we even get into that, you're probably watching this video and you're asking yourself, what is status epilepticus? What it is a continuous epileptic seizure that typically lasts for about 5 minutes or more, or it can be multiple episodes of seizures within the time frame of 5 minutes, but there's no recovery in between. All right, so that's what status epilepticus is. Now, what is the IV drug of choice, first line, to manage it? So the answer is Ativan, lorazepam, okay, which is a benzo. That's your first line. If that doesn't work, you can try phenytoin. All right, and then in terms of IM, you can use midazolam, which is also a benzodiazepam. Okay? So that's it. Next, we have a 24-year-old patient who was involved in motor vehicle accident. This patient experienced a brief loss of consciousness. And then after that, he also went through a period of lucid interval. All right? So, first phase, there was a brief loss of consciousness. But then they wake up and as if nothing happened. Wondering what just happened, right? There's another phase of lucid interval. Everything is clear. What are you thinking this is? So this is epidural hematoma. Okay, tend to be seen more in this, and in later on I'm going to discuss subdural hematoma. And one of the ways I remember both of them, and apart from the imaging distinctions, we tend to see epidural hematoma mostly in young people, right, involved in an accident, as opposed to subdural. We tend to see that mostly in elderly people, all right? And we're going to talk about this more. So, but just to make sure we understand this, because this question, always, you will come across this question, right? Look at the age, 24, right? Involved in motor vehicle accident. Initially, he had a brief loss of consciousness, and then after that, there was an interval of a lucid period where everything seemed okay. So that's a typical presentation of epidural hematoma, right? Next, what artery is most commonly ruptured when it comes to epidural hematoma? Again, a very frequent question that you're going to see when you're taking exams. What is the imaging of choice, and how do you treat it, right? So the artery that's most commonly involved is middle meningeal artery. Okay, you are going to get this question, guaranteed. And in terms of how you're going to diagnose it, it's going to be head CT scan without contrast. Again, sometimes they can give you CT scan with contrast or CT scan without contrast. It's going to be without contrast. What are you going to see when you order a CT scan in someone whom you suspect epidural hematoma? What are you likely going to see? You're likely going to see a biconvex, or sometimes they refer this to as lens-shaped hyperdensity that does not cross suture lines. Sometimes I've gotten this question wrong because I knew it was biconvex. I knew it was lens-shaped hyperdensity, but I did not pay attention to the fact that it does not cross suture lines. That's why I had to put not, right? N-O-T in capital letters. It does not cross suture lines. All right? Pay attention to that. Very important. So in terms of treatment of epidural hematoma, you're going to do evacuation of the hematoma, or you can do craniotomy, right? That's like some surgical procedure. Next, we have a patient who presents with slurred speech, loss of vision on the left eye. So slurred speech, they are losing vision on the left eye. You note sudden weakness and paresthesias on the left arm. But this all resolved within 30 minutes. What are you thinking? I'm going to give you a few seconds to see if you can figure this out. All right, so let's look at this again, right? This patient comes in, they're having difficulty with speech. They have lost vision on the left eye. You also note sudden weakness and paresthesias on the left arm, but it all cleared within 30 minutes. This sounds to me like it is TIA. TIA is transient ischemic attack. Okay? So that's basically when you have loss of blood supply to the brain, but it's transient, right? It's not like stroke that will last for a very long time. But this is a warning sign. If you have this, if this has happened, it's a sign that stroke is not very far away. All right? And then I got a question on this when I was doing my clinical rotation, and that's why I added this question here. And my preceptor basically wanted to see, how much I knew. and she asked me, the person had TIA, and she wanted to know what I would do with the blood pressure. The blood pressure was also high. All right. So that's why sometimes, when you get a certain question, it stays with you basically for the rest of your life. So it's important to remember that when someone has TIA, okay, they're likely going to have elevated blood pressure. And, on a normal day, when you see somebody's blood pressure greater than 200, you want to do something about it, because that's not normal, right? You want to look for ways to lower it, to prevent hypertensive emergency, prevent end organ damage, and so on and so forth. But the exception is in this case. Someone has TIA, do not lower their blood pressure unless it is over 220 systolic or over 120 diastolic. Okay? And then in terms of treatment, you want to give antiplatelet such as aspirin, or you can give clopidogrel. And then you can also do carotid endarterectomy. Okay, I struggle to pronounce that. So that's basically where they go in and open up the internal carotid artery, because it's stenosed, it's occluded, it's blocked, right? So that's important. That's how you take care of this. Next, what is the most common type of stroke? What does the acronym FAST mean in terms of stroke? Okay, the most common type of stroke, you need to know this, is ischemic stroke. And that's a fancy way of saying that some type of plaque or blood clot blocks the blood vessel that supplies blood to the brain. Okay, this is typically your internal carotid artery. So when you have a blockage, okay, in the vessel that provides blood to the brain, that's ischemic stroke. So you've probably come across the acronym FAST, F-A-S-T. And what that really means in relation to stroke is the F stands for facial drooping. Remember, at the beginning of this video, I told you that I'm going to walk you through some of the signs and symptoms that you're going to look out for when you are suspecting that someone has stroke. Now, you don't have to be a medical profession to know that. Maybe you're living with your grandparents and they're acting in a strange manner, right? And you're wondering what is going on. Maybe you've watched this video. So these are the things you can look out for. And if you see those things, right, what do? You can call 911, because time is essential. Time is critical. When it comes to stroke patients, time is everything. Time is life. So the F is facial drooping. The A is arm weakness. So let's say you're having dinner, talking to your grandparent, and they start exhibiting these signs, right? And you watched my video. Something is going to ring up the bell in your head, and you say, wait a minute, I heard this before. And that will prompt you or trigger you to call 911, because time is everything. So watch out for facial drooping, arm weakness, slurred speech. You're going to be struggling to speak, right? And then you need to act. Okay, time is everything when it comes to stroke. Next, we have an elderly patient who was taking a shower 2 days ago. Unfortunately, she fell. Then you notice there's weakness on the right side of his body, right? In this case, the patient is a he. You notice there's a weakness on the right side of his body, and he feels dizzy and confused. Okay? He feels dizzy and also sounded confused. What is the diagnostic imaging of choice? First, we need to figure out what this is. Okay? There's an evidence of trauma. So this patient fell, sadly. It's an elderly patient, and we know that in elderly patients, elderly patients are prone to falling, right? Unfortunately, as we get older, we start having issues with our balance and gait. So this patient fell while taking a shower 2 days ago. And then there's weakness on the right side of his body, and the patient feels dizzy, also sounded confused. What is the diagnostic imaging of choice? Which blood vessel is most commonly affected? So this is at the point where I have to take you back to epidural hematoma, which tends to happen. I'm not saying it doesn't happen in adults, but I'm not saying it doesn't happen in elderly patients, but more predominantly we tend to see it in younger patients, right? So as opposed to subdural hematoma, which we tend to see more often in elderly patients, right? Maybe they had a fall while getting into the bathroom or while walking around, and maybe they didn't tell anybody, or maybe nobody was there to see it. Then a few days after, in this case, they start exhibiting symptoms, right? So this to me is subdural hematoma. Again, anytime you're worried about somebody falling, fracturing something, having some kind of bleeding, you want to do a head CT scan without contrast. Because what that does is it will be able to highlight if there's bleeding going on, right? That's what you do, the head CT without contrast. And what are you going to see? You're going to see concave slash, sometimes some books, some exams will describe it as crescent-shaped bleed that crosses the suture line. This is where, again, you have to make the important distinction between epidural versus subdural hematoma. Because in epidural hematoma, it is biconvex, right, lens-shaped, and it does not cross suture line. However, in subdural hematoma, it is concave or crescent-shaped bleeding that crosses the suture line. In epidural, it was the middle meningeal artery. In subdural, it is the rupture of the bridging vein. Okay? Rupture of the bridging vein, not bringing vein. I messed that up. So it's bridging vein. All right? Very important. Next, tell me the 3 types of ischemic stroke that you know. How do they present? Okay? 3 types of ischemic stroke. How do they present? So one is middle cerebral artery stroke. It is the most common. I got a question on this before. Then you have the anterior cerebral artery stroke. You also have the posterior cerebral artery stroke. Okay? So the question is, how do they present? In terms of the middle cerebral artery stroke, we already established is the most common. It's going to present in a patient is going to lose contralateral sensory and motor deficits, and it's going to be more so on the face as well as the arm. Okay, so if someone has stroke that affects the middle cerebral artery, they are likely going to present with contralateral sensory and motor deficit. And what this is a fancy word of saying, if the stroke happened on the right side, right, you're going to notice it on the left side. That's just what it is. Okay, that's what contralateral sensory and motor deficit is going to present more so on the face and arm as opposed to on the toes, right? So you're going to see it more so on the upper extremity more than you will see it on the lower extremity, and it's going to be on the opposite side. So if the vessel was occluded on the left, it will present on the right. That's what this is. So another thing to look out for is they're likely going to have loss of visual fields, again, on the opposite side of the stroke. So if the blood vessel that was occluded or blocked was on the right, they're going to lose visual field on the left. You know, in medicine, they have a way of confusing you with so many jargons, right? They make them look like they're very smart. That's what it is. Then there will be aphasia. Aphasia is basically inability to speak and comprehend language. Okay? So if they're having Broca aphasia, it's going to be inability to speak. If they're having Wernicke's aphasia, it's going to be inability to comprehend language. All right? So next, you could see spatial neglect. So this is basically where they lose awareness of one side of their body. So I hope this provides you some clarity when it comes to how when it comes to stroke that affects the middle cerebral artery stroke is going to present. Next, anterior cerebral artery stroke. So again, if someone has a stroke that affects the anterior cerebral artery, they're going to have contralateral sensory and motor deficits, more so on the leg and foot, as opposed to on the face, right, and arm, as we saw in the middle cerebral artery stroke. So basically, this is opposite, right? So in the middle cerebral artery stroke, they will lose contralateral sensory and motor deficit greater in the arm and face than in the legs and foot. However, in the anterior cerebral artery stroke, they're going to have the same thing, which is contralateral sensory and motor deficit greater in the leg and foot than on the face and arm. So they switch basically position, right? But what is different in the anterior cerebral artery is that the patient is likely going to have urinary incontinence and also contralateral homonymous hemianopsia. Again, talk about medicine, throwing so many complicated jargons, right? So they're likely going to have urinary incontinence as well as contralateral homonymous hemianopsia. Again, a fancy way of saying they're going to lose visual field on the opposite side of the stroke, right? That's what that is. And another thing you're likely going to see is cognitive deficits such as confusion, impaired judgment, and flat affect. Very important. Then next, posterior cerebral artery stroke. Here you want to keep an eye on the 3 V's. Okay, so the other ones we talked about, we're talking about contralateral loss of sensory and motor deficits. But this is the one that is talking about vertigo, which is a sense of movement. So you stay in the room, you feel like the room is moving, but it's really not moving, right? So that's posterior cerebral artery stroke. You see things like vertigo, vomiting, and visual changes, again, such as homonymous hemianopsia. All right? So this one is, I believe, very easy to recognize. So remember the 3 V's: vertigo, vomiting, visual disturbances. Then another question is, you have a patient who is presenting with sudden, intense thunderclap headache. And they're going to describe this as the worst headache of my life. Okay? Again, going back to when you're reading a clinical vignette, there are specific things that will clue you to what they are asking, to what the answer is. It says sudden. It wasn't a gradual thing, right? It wasn't insidious. It's sudden, from nowhere. It's intense. It's like thunderclap headache. And patient describes it as the worst headache of their life. What are you thinking? That is subarachnoid hemorrhage. Okay? And what that is bleeding between the arachnoid membrane and the pia mater. Okay? And next question, I believe we're coming close to the end. You guys have been wonderful. We're almost done. So, what is the most common etiology of subarachnoid hemorrhage? And what are the two most common risk factors? And how do you diagnose it? Okay, the most common etiology of subarachnoid hemorrhage is when you have a ruptured berry aneurysm. So if there's a ruptured berry aneurysm, that's your number one cause of subarachnoid hemorrhage. Okay? The two most important risk factors are smoking, tobacco, okay, and hypertension. Because the more your blood pressure is elevated, the more the aneurysm is likely to be ruptured. Okay? In terms of the imaging, you want to get a CT scan, again, without contrast, because you want to appreciate if there's bleeding. That's your initial test of choice. And if that doesn't get you what you are looking for, you can do a lumbar puncture. Okay? So you suspect, you have a high suspicion of subarachnoid hemorrhage. Number one, you do a CT scan without contrast, but it's negative. But you really still believe that this is subarachnoid hemorrhage. You can get a lumbar puncture. And you are likely to see what they call xanthochromia. Basically, it's a mixture of yellow and pink of the CSF, cerebrospinal fluid. Okay? I believe that's it. Thank you for watching. Leave your comment, share the video, subscribe. If I missed anything, let me know. I can always make another video and correct it. All right? Appreciate you guys, your massive support. Always watching, always sharing, always liking. God bless you. Stay blessed. Stay healthy. Thank you.